Okay.
All right, thank you. I hope everybody's got their breath after the emergency preparedness review. It was very detailed and great expectations are made on everybody. Now, this one, many of you may have gone through one, but we want to just teach you how to handle the plan of correction. And what we're seeing is right now, especially as we have a large majority of our audience in Michigan, the state is doing COVID and emergency surveys in the clinics. That can include a full RHC survey, but they're triggering through a COVID or an emergency plan survey to make sure everything is in place. We have been experiencing some clinics that have received plans of correction. And so we feel that this is really timely to go through what it is, how to handle it, what the expectations are. Now, of course, being a rural health clinic, you can have surveys at any given point. And I'm trying to get my slide to move. There we go. So what our goal is today is to understand the purpose and reason of the plan of correction. I'm going to refer to plan of correction now from the rest of this lecture as POC. Some of the deeming entities have different abbreviations, but it all means the same. You will also understand specifically to the state of Michigan what the expectations are and how to address the document, but the same expectations fit Quad ASF and the compliance team. And then what to do for follow-up after you have a POC, after you've responded to the POC. What is expected for continuing monitoring and maintaining the RHC to assure that you don't have any future infractions of the listed deficiencies. Well, the main purpose is these happen upon survey, and an initial certification as well as a recertification, or as we are experiencing right now, a COVID survey. And so there's different methodologies that they falter to. And so I want you to understand you can get a plan of correction on your initial certification. What happens here is if they come in and they're doing your first survey for your certification process, you have to be 100% compliant. If you fail to be 100% in compliance, you will get a plan of correction or statement of deficiencies, some of the entities call it. What will happen is your certification will be on hold until you have corrected, documented, and the day that your plan is submitted and received, and then the final step is accepted as written for correctness, that will become your RHC certification date. So let's say you had a survey on the 10th, and then you got your plan of correction because you did not meet 100% compliance as a new RHC. And then you get your documents, you fill them out, you send them in, and you don't respond until, say, the 16th today, and they accept it and they approve it. The 16th will become your RHC certification date, not the date they were physically on the premises, which was the 10th. Now, in a recertification process, I want to assure you that you are still going to need to be 100% compliant. And what will happen is you will have your recertification survey, and whatever is found as deficient, you will receive a plan of correction. The thing about the plan of correction is every time that issue is listed within the federal guidelines for RHC, that is how many times you'll get that deficiency, and you must respond to it each time. So you may have something in regards to, again, the emergency preparedness plan, and however many of those that you're missing, say you don't have a plan, every one of them that addresses needing the plan, you have to respond each E number is what they're called. We'll go through a plan at the end here. But for recertification, the way this works is you will have deficiencies potentially, and you will be given an opportunity to make that correction. Now, I've been asked questions before. Does this put our RHC on hold? Does it negate our RHC? If you are already an established oral health clinic, this does not put you in jeopardy of losing your RHC because of the POC, unless you ignore it, or unless you don't follow the timelines that you are given or respond and provide the supporting documentation for evidence. So can you get decertified? Yes. The number one reason you would get decertified is you ignored the plan of correction, you went deficient with responding, and then the state has recommended to CMS to decertify you as an RHC. In the 13 plus years I have worked as a consultant with HSA, I have never seen a clinic get to the point of decertification because of a plan of correction. We fix it, the clinic fixes it, you get it sent in, it gets adjusted, it gets accepted, and then you continue to receive your continuation of RHC. There are some timelines that we will be talking about here shortly as well. And I just want to let you know, one of the things you will receive after everything is done, if you are in initial certification and then your plan of correction is completed and received and accepted, then you will receive your approval letter. And if you're with a deeming entity, you'll get their approval letter, and then you will also get the CMS documentation, which we call the tie-in notice, which shows you are accepted, your date, who your MAC is going to be, and your new CCN number. If you are in recertification review, you will receive an approval from the state that you are deemed able to continue and approved as an RHC. Now, how often does a survey happen, a recertification? It varies. Now, if you're using the deeming entities, they have a great timeline. When you're self-reporting, at least every 3 years on site. If you're through the state, that can be variable, and I know we have multiple states listening in here. That depends on how active your state is getting out there doing research. Remember, an RHC recertification is a tier level 4, so it doesn't take a priority. And here in Michigan, if you've been deemed through the state, I have actually seen up to 16 years between surveys. And when that happens, and staff turnover and just different processes, or not keeping up with the regulatory update of the guidelines, Appendix Z, G, emergency preparedness plan, if you've got that, you can plan on a large plan of correction. I believe the largest one I've seen has been 42 pages typed. The largest one I've had to participate in assisting with was 28 pages. And so they get kind of big and they get cumbersome, and some of it is repetitive in responding. But no, this is important and you must have this completed. This also, the purpose of this is to assure the clinic is in compliance with the federal guidelines that are set forth for the RHC to operate on a daily basis. As Tressa went through yesterday, the regulatory guidelines of what is expected to function as an RHC, that is on a daily basis. When I went through yesterday afternoon and talked about monitoring the compliance, that is making sure, again, that the assurance is there that the RHC is operating on a daily operational basis under those guidelines. And then this is the POC comes in because an actual surveyor came in and still found deficiencies, even though you may have had different checkpoints. Again, as I mentioned, the RAC can be put on hold, the recertification, there's timelines and expectations. As far as standard versus condition, I've always taught that a standard is kind of an oops, like, uh-oh, we missed that expired supply. A condition, which can really put a lot of scrutiny within the POC, is you don't have a mid-level. You haven't got a policy manual, or you haven't updated and reviewed it as according to policy. You used a single dose vial and turned it into a multiple use. That's a condition. And so there's a difference of how we look at those, and there's a difference in how they really need to be viewed by the surveyor as well as addressed. There's more microscopic scrutiny under a condition than there is a standard, even though they're both deficiencies. So for the initial certification, again, you'll be put on hold. Recertification, if you ignore it, you can risk decertification as being an RHC. There are timelines that you need to be aware of. What happens is the surveyor comes, and for the state, the survey can take place, and they will come and they will conduct the survey. And if it's initial or recertification, I want to tell you, with state or deeming entities, the day of your survey, they will always give you an exit interview. Please attend that exit interview, take copious notes, because you can begin working on the corrections right away. And then there's not so many surprises when you get this document. But if you have a recertification, what the state timeline is they have 10 business days from the date of the survey, recertification survey, 10 business days, that's Monday through Friday, and then the next Monday through Friday, to get the POC to you. When you receive it, it'll have a date on the letter, and it's mailed. And so when you get this, it starts on the date of the letter. And then you have 10 calendar days, which includes weekends, to give a written response. If, and we have had this happen, if your clinic receives the plan of correction after the 10 calendar days that you were supposed to have given a response, what I recommend is you immediately, there's a person on that letter, you contact them immediately and express to them, we just received this. Yes, the letter is dated on this date, but we just received this today, and ask for an extension for another 10 calendar days. I have not heard of any state not granting that, but you can't just ignore it. If it's beyond that date, you need to reach out and say, hey, this isn't our fault that it didn't get here in time, but we need the 10-day extension to prepare and complete this. So what are the expectations? Well, after survey, again, as I said, take copious notes during the exit interview so that you can begin to prepare for the plan of correction. Begin making those corrections for the issues and concerns that were stated. And so, for instance, an example would be one of your deficiencies was you had multi-use vial open date, and it had already exceeded the 28-day pharmaceutical guidelines, and so it should have been discarded already. Well, you can start working towards training staff, working with staff, putting in processes that can make this not happen again. So use the exit interview as a guideline to begin making the corrections immediately. You can start making those corrections, but you still have to wait for the official plan of correction. You cannot respond back to the deeming entity or to the state until you have this written document. You can start making the corrections in the clinic, but you have to wait for this official plan of correction before you can give your full response back. So that's why I say the exit interview can be very beneficial for you, and you can start making the corrections. and that just will look favorable when you do the completion of the description of how you handled it. When you get this plan of correction, read through it. Read through it thoroughly. Understand what deficiencies were identified. Sometimes you will have an exit interview and you will be told just the big stuff. And then when you get the plan of correction, there may be some additional things listed in that document. Or you may have been told during a exit interview, these are deficiencies. And then when you get the plan of correction, you're looking for it and it's not there. Don't call and don't say, well, you told me this was a deficiency. What do I do? Don't ask for more. Just read through it. And if something was not addressed that was mentioned, that may have been that surveyor's recommendation. And then when it went through the second level of review to send the plan of correction to you, somebody may have felt that, okay, this really is more addressed in this other one that they've already written. And so they may not have addressed it specifically. When you get a plan of correction, it is set up in a table. And of course, across the top is all of your header information. The left side is the actual statement of deficiency. And you will see it'll say a J and it'll give the number, or it'll have an E for the emergency plan and it'll have numbers. And it'll even describe who the surveyor talked to, the position that they talked to, what the findings were. And then the right side you'll see is pretty much a blank column. And so that's where you put your response. So the left side is what they found as infractions, and the right side is where you use that document, and you must respond on that document. You don't get to write a letter and attach it. Your responses must be in the right column of that plan of correction. Typically, they come in PDF. Hopefully you have a way that you can convert it to Word. If you can convert it to Word, do that. You can type more freely in it without, you can type more freely in that column with a Word than trying to do a text insert and all of that with a PDF. If you can't convert it, then you just do your text insert and stay within the box of that right column. But if you do it in Word, I always say, please convert it back to a PDF to submit it. PDF locks it and it protects that information that you put in it. And so always, you can convert it over to type in it, but then convert it back to a PDF for submission. As I have mentioned a few times, you have to address each deficiency, even if it seems that it's duplicated. You have to address it with full detail. And then the nice thing about being in Word, it's a lot easier, I find. Again, not my superpower of technology, but if I do it in Word and there's a lot of repetitiveness throughout the E codes or even the J codes, if the answer that you've written previously applies to this next code, you can actually copy and paste and put it in, but you can't ignore that J code or E code number. You have to address each one. Some of it, if it sounds like, well, we got hit on that already on this document, just copy, paste, and make sure it fits what the description of deficiency was. So in the state of Michigan, to be acceptable, you have certain things that you have to do. You have to type on that document in the right-hand column, and then you have to describe how the corrective action will be accomplished for those residents found to have been affected by the deficient practice. So what this means is you have to say, what did we do to do a corrective action on this deficiency? How are we going to accomplish this so that it is defined, taught, and communicated of how the corrective action is going to be. Also, how the facility will identify and be affected by that deficient practice. So what you're looking at here is the provider's POC. Again, this is right from their wording. It's a little legal jargon in here, but basically what these 2 points are saying is, this is our corrective action, this is how it has affected us, and this is how we are going to make the correction. What measures will be put into place, or what systematic changes are going to be made to ensure that the deficient practice will not recur. That is the full purpose of addressing this plan of correction. What they want to know is, okay, we caught you this time. How are you going to prevent this from happening again and continuing to be a bad step of practice according to RHC guidelines? You must also communicate in the POC how the facility will monitor its corrective action. And you want to be able to ensure that the deficient practice that you were caught on is being corrected, and that you are doing your best to make sure that it does not recur. And then the date that each deficiency will be corrected. What is your timeline? Do you have to do some trainings? Do you document trainings? Do you have, they'll want to set date of when you plan on doing these trainings. So you need to communicate very detailed. Never use names within the plan of correction. These are open as a community document. They can be viewed, they can be hunted down and looked at. And so for HIPAA and privacy, they do not want names. So you would not say, well, Robin Veltkamp's going to fix this. You're going to say the title and the position of who is going to fix this, who's responsible for fixing it. And if it's a different title and position, who's responsible for monitoring it. You want to, in the right column, I always recommend that you state the J code or the E code first, so that they understand where your response tags back to on the left column. I just find it works so much more fluent. If they've got an E003, then I put an E003 right there, and then I address everything. And then they can see, if I go into the next page and kind of go into the next E or J code, they can see that this communication of correction is matched to this side deficiency.
Robin, we have a question. The question is,
Sure.
Can you talk about how often a clinic could potentially have a POC? Is it only upon their recertification, or can it come into play at other times?
The main one is upon recertification. However, as I mentioned at the beginning, the state is coming out and doing COVID an emergency plan. So that can, it might start out as just a COVID and emergency plan. Most of the time what they're doing is they're doing a full survey. But because we're in this COVID, it is triggering. You may have had a state survey 2 years ago, and the guidelines do recommend 3 to 5 years that you have another recertification. But if you had one 2 years ago and you had a POC there, you need to make it corrected. But because of the COVID surveys that are taking place, they can come out again. Of course, the state can show up at any time. And another thing that can happen is if a patient calls and has a complaint, that can also trigger a survey. So it's not necessarily just your every 3-5 years. It's whenever a surveyor comes on the premises, if they find deficiencies, you will get a plan of correction. Great question.
Follow-up question. Are we guaranteed the state will come survey us periodically, or they only come when triggered?
Well, because you're a tier 4 in Michigan, they have not, let me back up a minute. Michigan will never conduct an initial certification. As of 2010, they've actually said they will no longer do initial surveys. And so that will always be a deeming entity. And then because you're in with a deeming entity, your recertifications will probably continue with those deeming entities. if you were an RHC prior and you were certified under the state, or if you are one of our attendees here that your state is conducting your surveys, the state is supposed to, it's recommended they come out every 3 to 5 years. They set the timeline, and sometimes it's a little earlier, sometimes it's later. And the bigger challenge that happens is the fact that, you know, they're unannounced. And so you never know when it's going to happen, and you never know what's going to be the trigger. Did that address that, Russell?
Yes.
Okay.
I think too, the clarification would be helpful that normally POCs are tied to a survey. Normally the process or the timeline for that survey, deeming entity is every 3 years. States should be every 3 to 5 years. We've seen it extended past that, but they may come in prior to that time frame. So whenever you're under survey, you should be in compliance every single day you're in RHC. But as you move outside of your initial survey and keep moving forward, you are always subject to a survey. So you should be prepared and ready for that. And another question that came up is if every RHC is having a survey for COVID, and the answer is no.
No. We had some groups that have had multiple clinics surveyed. We've had some independents that they had an individual survey, but it's not understood that every clinic's going to have that this year. It's a random, and we don't know what the determining random trigger is. The other thing that can become an issue that I want to make sure we address is make sure when the surveyor comes that you are getting a business card so you know who you're dealing with. If you need to reach out to people in your entity, let them know, hey, we're in survey. And especially if you're provider-based, sometimes you have to let the higher administrative people know. And also know your RHC guidelines. We've actually had clinics that have gone through an RHC, and you have to understand when you're working with one of the deeming entities, you are working with people that are being trained exactly how to look at the regulations exactly the same. When you're dealing with state, you're getting people that are doing this as supplement sometimes, and they're not necessarily groomed in RHC. They may be a nursing home surveyor, or they might be joint commission surveyor. We've actually dealt with that. And then what happens is because they're available, and especially if it's a nursing home and they're doing a nursing home in the community, and then they get tagged on to pick up your RHC while they're at it. And especially we have seen this in the Upper Peninsula sometimes, because they're not going to send multiple people that far. So people that are surveyors of other types may pick the RHC up. And so if something doesn't sound, give it the smell test, I guess is what I'm saying. If it doesn't sound like what you've been taught, reach out to somebody or reach out to us even and say, hey, we're under survey, we're being told this. Because you can challenge some of the things as long as you have the documentation of what you're standing upon. We have had a few where they got the POC afterwards, and it really wasn't written like an RHC survey, and we've gone to bat for them and assisted. And so that's why I say read the POC. Make sure it fits, the deficiencies fit what really fit in RHC according to the guidelines that you were taught yesterday. So in the right-hand column again, you are going to define some key things. Define the what, the who, the how, and the frequency. If you remember this one line, what, who, how, and frequency, you'll have the information to put in your plan of correction. So describe the deficiency. You don't have to rewrite everything that came out of the left column, who they spoke to and how they validated this deficiency. You want to give a summary of what was found, what was the deficiency, what was the summary of the deficiency. That's the what. Then you're going to describe the how the issue is going to be addressed. How do you plan to make sure the correction is made and the monitoring is going on, and that you're just describing and communicating how you're going to prevent this from being a future problem. And then you're going to include the frequency of monitoring. How often, if you put this into your plan, how often are you going to monitor this deficiency to make sure that it has actually been corrected? You also want to put in the who. Who is the person that is going to be responsible for the correction? Not the name, the title. The title of the person, the position responsible for correction, the position and review. Then I'm a big person where I am just saying, give the supporting documentation. If you can get some of the pieces done and you can show some of the evidence of training logs, a new written policy, any of that, I always encourage attach documents that support what your response is. Usually, not always, but usually if you give enough evidence of support that you have made this correction and you've taken this serious and you put that with your plan, it can be received a lot quicker. I do want to warn you, just because you've done a great job on addressing, you've sent supporting documentation, they can come back and do a second survey. And if they do come back and do a second survey, it is not just to address the items on the plan of correction. They don't come back with their plan of correction and go, we need to check these areas truly to make sure you've done a correction. They can actually do a full 100% compliance recertification survey. And I have had it once where the client called because they had done everything on the first round, which was fine. And then the state came back and did another certification survey, and they got a second POC on something different. So it can happen. It's rare, but it can happen. And if you have a lot of conditions versus standards, if you have a lot of conditions, you can pretty much plan, if there's a lot of them, that they will be back. And typically they are back within 45 days. So when you've got this all done, you've got all of your typed document on the right column that supports and addresses the left column. You've shown that you've got training logs, you've written a new policy, you've written your plan, and you attach all of this, then there's a required signature. And for the state, it is the first page of the plan of correction. It is down at the bottom. There is a signature and a date, and that is the authorized signature. It's not the office manager unless you're the authorized signature. It is the authorized signature, and that usually will match the letter that is addressed to whomever. Again, just to reiterate, you have 10 calendar days to submit this plan of correction from the date of the letter, not 10 business days, 10 calendar days. And then many times you can send it electronically, and pretty much all of them go in electronically now. And what I always, again, recommend is you've got this document, it's got a time sensitivity. I always hit read receipt, because then you know when it has been opened. And then I keep that email with that read receipt until I get back my continuation approval. But then if they come back and say, well, you never sent it, you've got this read receipt showing, hey, somebody opened it, we met the timeline. And now you've sent it in and you've gone through the knuckle sandwich a little bit, you've worried over things, and you just wait again. And what you're waiting for now is the approval letter, which tells you you are deemed to continue on as an RHC, or you may receive an email with additional request or clarity of your plan of correction. What I have found is if you are very detailed in writing the plan and you give the attachments of supporting documents, I have not had an additional request returned. we usually see the RHC approval letter. Now, if you're vague in your response on the right-hand column and you don't give any supporting documentation, and what you've written is, like I said, vague, it's really not detailed, they may come back and express that they need it more detailed, and they can do that. Again, what happens if you ignore the POC? I can't emphasize this enough. If it's an initial, your RHC status is on hold until you can pass 100%. Recertification, if you ignore it, you would be recommended in 90 days for decertification. Will the surveyor return? The ultimate answer is, who knows? You may only have had one deficiency and taken care of it, and you may have had 10 taken care of it and nobody returned. Depending on the number of conditions, sometimes tends to be a trigger. If there are issues or concerns, or it was such a condition that they feel they need to physically see the correction, then they may also again return. And once again, it's typically within 45 days, but it is once again unannounced. You will not know that they are returning. Okay, you've got your plan in, and you have figured out how you make this so it doesn't become a deficiency again. And you've gotten the plan sent in, and what I recommend is start right while you're doing your plan, create whatever tools you need, make it hand in hand. Don't come back and go, oh, I got to create this. Create them as you're going, because those tools can be additional attachments to support that you're, hey, we're taking this serious. So while you're waiting on the POC to be accepted, and then of course ongoing, put into place any additional items that may fall in people's job descriptions that you have put as part of the plan. So if you've said the clinic lead person, and it's okay to delegate some of these things, but if you've said the clinic lead person is going to do the monthly medication check, or you've got the pharmacy staff member, typically what we see is the lead clinical person is going to do the monthly medication check. Does that person know they're supposed to do it? And have you included it now in their job description, which helps you through your monitoring? And then create tools to assist whatever the deficiencies are. Create the tools to assist in monitoring. If it's medication and supplies, which we see frequently, then create a tool for whoever's being put in charge of monitoring medication and supply, checking for expiration dates, making sure that single dose vials are not being reshelved after they're open, making sure that the open and 28-day expiration date is on your multi-use. Create whatever tools you need to use. And again, as you're going through your plan, if this is something that you can show as a support tool with submission of the plan, it is very favorable. Create calendar of events to remind checking these items. You know, even if you delegate, as we talked yesterday afternoon, that monitoring and ongoing monitoring, and we said, go ahead and make that tool over and put dates on. If there's things that you got deficiencies on, you want to make sure that you're checking on them as well, and not just the person you've delegated to. And then be sure to review the POC and the corrective measures on a timely basis. That's a big thing that you want to know. If you've taken the pieces from the POC and you're creating calendar events, make sure that you understand there's timely basis that you need to be monitoring, and that you have to follow what you have written. And what you're basically doing is assuring that the issue has been resolved. In months or 6 months of resolution of what you received a deficiency on, and then periodically after that. This is a sample of a plan of correction, and all identifiers have been taken off, but this is an actual POC that we have assisted with. And as you can see, the top where it says sample would actually be where the identifiers are of the clinic and all of that. You'll see the first column is the CFR. So this is what we've talked about in all of the compliance lectures, the 491 CFR 42. And that's why we say keep up to date on the electronic version of any new and added guidelines. So on the first column is the CFR. What is the guideline that you were deficient in? Then they give a description. So the standard was not met, and it was at a standard level as evidenced by observation. And then during the clinic, the surveyor, and they usually have an ID tag number, found the following: the exam room, expired medical supplies. And they list out the specific expired supplies. So 12 of 12 specimen collection kits found beyond the manufacturer printed expiration date. Now, if you have a supply room and they go in there and it hasn't been maintained, this could become a very long list of expired supplies. They will list everything that they found. As you can see, 12 of 12, there was 12 in a box and all 12 of them expired. They didn't say a box, they actually counted how many expired and listed out that detail. And they'll list, if it's under this guideline, they'll list all of them. Now, you don't have to address every single one as an individual, but you will come up with is a plan that handles it corporately. Upon interview, so they talk to somebody, and then the person, the title of the person they talked to, stated the specimen collection kits were missed during monthly survey for expired medical supplies. The specimen kits were removed from stock and disposed of properly. So they took care of it right in front of the surveyor. They disposed of it immediately. Little not going to happen. You're still going to get a deficiency. There is the rare surveyor that will say, if you take care of this right now while I'm here, we'll be good. But most of surveyors, they found it. It was a deficiency at the time of finding, and they will give you recommendations on how to correct it. But they don't take it off if you always, they don't always take it off if you've made the correction while they're standing there. So they did make the note that it was taken care of, but you still got the POC for the deficiency because you took care of it this time. How are we sure when the surveyor shows next time that it's not going to be a replication of the same problem? Failure to store medical supplies based on the manufacturer's guidelines, and they explain why it's a deficiency. Puts patients at risk for receiving ineffective or harmful treatment, and the clinic out of compliance with Medicare 42 CFR 491.6. They list it all out. This is a very regulatory document. To meet this standard, the clinic must have a process that ensures clinic medical supplies are stored according to the manufacturer's guidelines. They're giving you some advice here on how to fix this and how to address it. All staff shall be trained on this process, and evidence shall appear in a training log. So when you read, this is why I say read it, because this is giving you the direction of correction and evidence show that you fixed it. So when I read that paragraph, I'm going to be addressing how I'm fixing it. But then all staff shall be trained on this process, and evidence shall appear in a training log. I would put in whatever policy change was made or a training agenda, and then I would attach all of that and the training log. Now, again, that's got names, so you're going to want to put a line through the name, but if you can show dates and things like that, and even though it's got lines through it, they can see that a log was done. You attach that and send it, they can go, oh, okay, they fulfilled what we were expecting. The clinic shall monitor all elements of the corrective action until initial compliance is received. Remember that slide where I said, create the tools, create the check timelines, go in and monitor? This is part of the monitoring process. You have to monitor the problem until you know you have achieved and you're able to perform periodic environmental rounds that support ongoing compliance. evidence of compliance, how compliance will be monitored, and verification of staff training must be provided. This is talking to you. This is telling you what you need to do to fix it. These are the things you don't want to ignore. And that's why if you don't address them on the right-hand side, they may come back and say, no, we need more detail. Any questions so far? Okay, so how do we handle this? What you can see is, I don't know what E code, then E say 0023. And so what I would do on the right-hand side is above where plan of correct deficiency is, I would type that E023 if that's what's on the left-hand side. I would put it parallel and I would put in the E code, the J code, whatever code it is. Then I like to use this format myself because I think it addresses all of the elements, and this works for all of the deeming entities as well as state response. What is your plan to correct the deficiency? So list what the deficiency was. Summary. Exam room had expired medical supplies. You don't have to list all of the supplies that may be on this, but what was the overall problem? Expired supplies were located in the exam room. So then what is my plan? And what is my procedure? What is my plan to correct this? What am I going to do? Am I going to do some training? Am I going to assign a specific job person by title as overseer and mandate doing a monthly log that they do checklists and back to you? And then what is your procedure for implementing the plan? How am I going to implement? This is my plan. Now, how am I going to implement it? What are my steps to make this happen? What is my plan completion date? When do I expect to have this fixed? Are there multiple dates? So I may do a training and put the date of that. And then I may state an office manager is going to do a monthly check on the status on the 30th of each month. However you plan to complete the plan, your dating of completing the plan. Monitoring the procedure to ensuring the plan is effective. How are you going to monitor this? What are your steps? What are your timelines? Weekly, monthly, quarterly? And then the title of the staff responsible for implementing this change, the title of the staff. And then I always put in here, evidence of correction documentations attached, and it's yes or no. And if you put a yes, then make sure whatever attachments you have go with that or that particular code. What are some common deficiencies that we are seeing? And I know we are really going to end early here, but we will open up for some other questions as well. The big one we are seeing is emergency preparedness. If you do not have an emergency plan, and yes, there are still clinics out there that we have discovered do not have a current emergency plan. If you do not have a plan, you are going to get a very large plan of correction. If yours is a provider-based and they don't see specific clinic identifiers, it is totally a hospital plan of correction. The surveyor basically looks at that as you don't have a plan of correction. If you have an incomplete plan of correction, you will get whatever areas in those E codes that are missing, you will get a deficiency for that. So when Tressa took you through the emergency plan earlier this afternoon, if you look at all of those elements and the guidelines and add in all of the elements that she discussed, you won't miss anything that's in the regulatory guidelines. And so you want to make sure that you have all of the pieces. Some of the things that we're seeing through the emergency preparedness deficiency is, especially in the integrated one, where you just take from what hospital gave you, is you don't have an individual risk assessment for your clinic, or there's no evidence of your clinic in included in that risk assessment. You don't have certain things addressed. You haven't addressed communicable diseases or infectious viruses and diseases, I think is what it's called. Another deficiency we're seeing, a big one, is medication handling. The biggest one we're seeing is up to the multiple use, not having a expiration and not being discarded within 28 pharmaceutical days of guidelines. Or the big one is the single use, possibly having it opened and then putting back on shelf and being assumed that it is being used as a multi-dose. Supply handling, if they go in and they see a sterile suture kit and the scissors are out and the rest of the flap is still sitting on the container and it's sitting there, it is no longer considered sterile, and you can actually get a deficiency for it sitting there because you haven't disposed of it. Supplies, member supplies have expiration dates. And I know a few years ago I was really surprised and really hammered about the wood tongue depressors having an expiration date. But make sure you're checking that. How do you help with this is we've always taught, especially if you're provider based and Central Supply sends you supplies. Sometimes things are sent to the clinic because it is assumed that you will use it up quicker. And so sometimes it's hugging that expiration date. I've always had the rule, don't receive it if it's within a couple days and you know you're not going to use it before the expiration date. Never receive it if it's already beyond the expiration date. Because remember, it's not the Essential Supply that's going to get the deficiency and the POC. It's the clinic. So you want to make sure as your staff are receiving supplies, medications, lab tubes, any of those kinds of things, make sure that they are not expired or extremely close to expiration date and you're not going to use them up before that. Make sure any policy review that you had to change any policies because of the plan of correction, make sure that those are included. And also a common deficiency is the overall policy manual. There were no signatures for update. And so then you have to address that. You haven't conducted your program evaluation meeting either annually or biannually. You have no meeting minutes to show evidence of that meeting. And it's past the timeline of allowance. Chart audit failure. When they do come and do surveys, they do the administrative chart audit. And you can get deficiencies. Now, what they typically have is a tool, and it's a table, and they'll do 10 to 20 charts, and they'll look at all the elements that were covered in the administrative chart review yesterday. And if it's evident, they'll put a check mark. If it's not there, they'll put a circle. And at least the surveyors I've witnessed and done oversight with. And then what they do is they see one whole row, consent to treats, is all zeros. You're going to get a deficiency for not having effective consent to treats. The other thing that they look at is if they look at this total tool document spreadsheet, and if you have more zeros than you have X's, your medical record audit failed. And that can also be considered a deficiency. The clinic doesn't have a medical director. Surprisingly, you know, that has happened. They retired, you haven't had time to get the new one, and surveys took place, and you haven't made accommodations for oversight. No mid-level in the practice. I know we talked about this yesterday about if you lose your mid-level, you have the 90 days, but you need to show your tracking and your record of how you are handling replacing a mid-level. Or the mid-level is not doing the 50%. They'll look at your schedules and they'll see what your hours of operation are, and then they'll assure that your mid-level is performing or available to perform services at least 50%. of the scheduled patient care hours. Jill, a question?
I think Tressa is answering it, but the
Okay.
question was, my clinic's attached to the hospital as an RHC. I should have an emergency preparedness plan for my clinic and not rely solely on the hospital.
What I
Tressa's
told,
going to address that, but that is correct.
so what I responded is that they'll want to review the emergency plan to ensure that all regulations are being met, and then also to be sure that it can be enacted within the clinic. I do want to also state, I have reviewed emergency plans that are integrated into the hospital, and they have been successful at survey because the clinic is reflected in the plan.
Correct. So that's the big step, is making sure that the clinic is being seen within the plan. The hospital may have created it, but they need to be sure that the clinic is being addressed within that plan. And where you'll get the deficiency is if there's no evidence of the clinic, it's just the hospital's plan. Another issue is you may have a practitioner there and you don't have an updated license, current licensing. And so that can get you a deficiency, and then you'll have to put in a plan of how you're going to assure that you're obtaining and keeping current copies of license. Another big area we see common deficiencies is in regards to instruments and infection control. Especially more so in the last 2 years, we're seeing a real high emphasis on infection control. And now with the COVID, infection control again is being checked very microscopically. Instruments is going to be a potential deficiency. If it is not shown that that instrument has been sterilized in open position and stored in open position, and the packet is not punctured, you actually could get a deficiency on that. As far as medications, one time, and so I want to give you this warning. I don't know if this is, I've only had this happen once, but I want to give you the warning because we are coming into flu season. Read your vials. And some of you, many of you have gone to just a single syringe, which is fine. But read your vials if you're doing vials. It is a multi-dose, usually 10. And what the bottle says is 10 doses. That means 10 draw-ups for an injection. Well, we know pediatrics usually only get a half a dose at a time. And a surveyor went into a clinic and they discovered, and the clinic actually got the deficiency because they turned the 10 dose vial into more than 10 dose because they were drawing up pediatric half dose, but exceeded the 10 doses that was listed on the bottle. Now, we really tried to fight that one, but that surveyor dug their feet in the ground. And so I've seen that once. And so I just want to give you that warning when you are looking at your flu injections this fall. And that is a lot of why a lot of clinics are going to the already syringe refilled. But if
Robin, we have, oh, go ahead.
But if
I'll let
you
you
have
finish
a
your thought.
multi, make sure you follow the number of doses that is on that vial. Yes, Tressa?
We have a question. Would we have to show the malpractice insurance for our providers to auditors?
I have never had that asked to be seen. With surveyors, I have not known of surveyors to ask for the malpractice. That is more, they may be checking it, but I have never been aware of a surveyor asking to see that. Now, if that's a question that you have, if you have current malpractice, then you want to make sure that that's all taken care of. But I've never seen a surveyor ask to see that. Okay. Autoclave, that is another one that will get you deficiencies. If you have one on the premises, then you need to have the manual, the manufacturer guideline manual. And if it's so old that you don't have the manual, Google the machine with the serial number and print new manual. And then you are expected to follow an autoclave according to the manufacturer's guidelines. So if you have an old autoclave and you use it periodically, make sure you have manufacturer's guidelines, because they can pull it up in Google too. And then they are going to make sure that you have the solutions that's recommended by the manufacturer's guidelines, and that you are following the exact steps for that particular autoclave. And we have seen deficiencies in this area. We've seen some deficiencies in patient safety issues, that if there's a safety issue and you've ignored it, that's a risk. And so they may address that under the patient safety J codes. Missing HR elements. When they come, they will do an HR audit, just like they do the administrative card audit. And they're going to be looking for key HR elements. And if you're missing, say, the OIG report on all of your staff, that can be a deficiency. If you're missing I-9s, that's a big deficiency. If you don't have signed job descriptions, they can get after you for that. So whatever Tressa went through in compliance, go through those slides again, make sure that you have the elements in the way that she has stated you need to have them, because surveyors are going to be looking at exactly the same thing, and you don't want to get caught in needing a POC and having to do this whole correction. If you don't have an emergency, go ahead.
Oh, in relation to the missing HR elements, the main one we see, especially in the state of Michigan, is that collaborative agreements are not in the personnel file.
Yes. Some states, you don't have to have a collaborative, or some states have a collaborative for like the first 3 years that the person is out of school. And then once they have 3 years of practice experience, they don't have to have a collaborative. Michigan does require collaboratives, and they do want to, the surveyors will look for that collaborative within the documentation. No emergency kit. If your RHC is in the hospital and the emergency room is across the hall from your clinic, yes, your clinic needs an emergency kit. Does it need to have a full crash cart? No, but you need to have your medical director work within your group as to what you need to have in this emergency kit for your clinic. If you are off-site, you need to, again, work with the medical director for what categories you most deal with, but you do need to have an emergency kit on the premises of the 4 walls within the RHC.
As a side note on the emergency kit, Robin, if a emergency kit looks like it has a small amount of contents, the medical director or the person that they've defined in their policy as the person who determined those contents may be asked to defend why those contents were decided on.
Correct. The surveyor can interview anyone within the premises, including the medical director, and if they're not in the premises, they may be reached to defend, as Tressa said, why it is so sparse, or it doesn't cover multiple categories. It only has one of the classifications in there. And also, as Tressa mentioned yesterday, in your emergency kit, have the documentation on the outside as to what the contents are, and have that same list written within the policy. One of the things that's going to happen when they come and do survey is they're going to pull policies, and they're going to look through them, and they're going to follow some of them to make sure that you're doing what you've written down that you're going to do. And so you want to make sure that all of that is in place. Again, if you take yesterday's teaching and you implement it and you really focus on that and you remain 100% compliance, you don't have to worry about the plan of correction. But they do come in, they have a purpose, they're monitoring and maintaining from the state level for CMS. Remember, when they come in, they're coming in as eyes for CMS. So they're making sure you're following compliance. And you are to be following it 100% daily operations. And they will come in unannounced we don't always know what the trigger will be as to what brings them in. But if you don't pass 100%, you will get a POC. And so that's why we felt this is timely right now, because we are seeing a few more pop up recently, and how to address and how to respond and how to incorporate the corrections as part of your clinic facility. Any other questions? I know you guys got hit with a lot today between emergency plan and plan of correction. It's a lot of information, but if there's any questions on the POC, let's take those first.
I'm not seeing any in the chat box.
Okay. And then the last two days we have done a lot on compliance and emergency plan. Tomorrow, our colleague Julie will be doing more of the financial cost reporting and those elements. I'm going to be honest with you, I know enough of that to make me dangerous. And she is very great at what she does, highly regarded nationally in handling all of these types of elements. So you're really going to be getting it from a national speaker and a very high quality presentations tomorrow. And she's very knowledgeable in the area. I have high respect for that knowledge area because I don't have it. But we have a few moments. So if you have any other questions for RHC that Tressa nor I addressed over the last two sessions, feel free to type it in and we'll do our best. If we can't answer it today, we will send it through our company and get an answer for you.
Robin, I did receive a question through text email, and the question was regarding non-sterile items. So the packages like non-sterile gauze, that is quite a large package, and then it has a symbol on it that has a circle with a 2 and it's crossed out. Is that able to be used more than once? And I did want to clarify that on here because I'm wondering if more than that individual would have that question. I actually took that question to the compliance team to ask, just specifically to see how they would view it. And the response back is they just cannot be used as sterile items. And so if you have a large package of non-sterile items, such as swabs, cotton swabs was the big one. We open it, we use 2 cotton swabs and we have 98 left. Do we really have to discard all of them? The answer is no, you do not have to discard them. Just very clearly define them as non-sterile and make sure that they're not used for a sterile purpose.
And you can put them in the containers on your counters, like the sterile square gauze. I do want to give you a warning because we've actually seen this happen. Under no circumstances are you allowed to take non-sterile gauze and try to autoclave it to make it sterile. We've actually seen that. They were trying to save money and they were taking non-sterile gauze, putting it in the packets, running it through the autoclave and considering it sterile. Absolutely not. That will get you a deficiency before they even get the door closed behind them. You know, it happens.
Thank you, Robin and Tressa. Always a wealth of information. As Robin mentioned, we do have Julie Quinn on stage tomorrow. She is absolutely fabulous at what she does. We know that COVID-19 has affected a number of different components when it comes to regulation and compliance, but it's also affected that back end of the financial reporting as well. So stay tuned in to tomorrow's session. That is from 9 to noon. And if anyone wants to stay on the line or throw a question in the chat box, we'll stay on for just a couple more minutes. I know sometimes it's hard to throw things in the chat box when you're listening intently. So thank you again, everyone who joined us today. We'll stay open for just a couple more minutes and then we'll give you 15 minutes back to your day. Thank you.
And also, if you think of a question